Tuberculosis is the silent killer, which is taking away more lives than any other disease or natural disaster has in recent times across the globe. And now, this ancient disease has acquired a contemporary edge. Its synergy with HIV puts the world face to face with a deadly partnership that accounts for nearly 30% of all deaths among people living with HIV/AIDS. Also, inadequate treatment for TB, coupled with the TB-HIV co-infection, is slowly giving way to newer, more potent forms of the disease. That is not just multi-drug resistance or MDR, but even extremely drug resistant. The TB bacillus already infects a shocking 2 billion people globally, more than 1/3 of whom reside in India and Southeast Asia. And today, TB is the leading cause of death for people living with HIV/AIDS, as they are 10 times more likely to develop TB. This has been seen in Africa during the last decade. The co-infection would be as devastating for people living with HIV/AIDS in Southeast Asia and India because of their high TB burden.
There are countries where the prevalence of HIV among people living with TB is as high as 68%. I mean, I'm talking particular about countries like Zimbabwe or South Africa. In countries like India, it's much lesser. However, the risk still remains. People living with HIV have the highest risk for dying of tuberculosis. That in itself is something to focus on and make sure that people living with HIV have TB as one of the components, TB services as one of the components in their care and service basket.
Civil society response to address TB-HIV co-infection is still insufficient, though NGOs are hard at work to address the TB or the HIV problem. What is required is an international and national effort to detect and treat TB in people living with HIV/AIDS. This calls for integrating India's National AIDS Control Program run by the National AIDS Control Organization or NACO and the revised National TB Control Program. This integration visualizes people living with HIV being automatically tested for TB and once tests are positive, being put on directly observed therapy short course or DOTS. Greater integration between the AIDS and TB control programs can yield vital epidemiological data, which is currently not available for most countries in Southeast Asia. It would also be necessary to ensure that patients take the complete treatment. Otherwise, they are in acute danger of developing multi-drug resistance and extreme drug resistance or XDR. Initial data from South Africa shows that XDR-TB in people living with HIV/AIDS is nearly always fatal. It's a deadly partnership of different pathogens whose grip has to be loosened now. People living with HIV/AIDS can die within weeks of acquiring TB. But this lethal combination can be dealt with through early detection and treatment. The standard TB treatment regime costs as little as $12 but can prevent death, especially among patients who are not yet on antiretroviral treatment or ART. ART for HIV/AIDS along with TB treatment can be administered together if needed, although care has to be taken to ensure that the two drug regimes are combined properly to prevent adverse drug interactions. But a more concerted effort is required by all stakeholders. The most urgent among them is the political will to integrate HIV and TB programs in a practical way. A beginning has been made by an active group of MPs in United Kingdom who have come together to form the world's first all-party parliamentary group for advocating issues of tuberculosis. And they have travelled around the world, including India, to help form an international wave of support for TB.
I think there's a lot that the HIV/AIDS world could learn from the approach used in tackling TB. I think because of the co-infection rates.
What I think we need to do, both with HIV and with TB, is see what can be done in an imaginative way to try and support treatment and identification and so on through communities. What can be done that can be put in place very quickly and easily, building on community structures that are already there, as opposed to having to develop complex Western style health provision, which takes a long time, a lot of money, and a lot of trained personnel to put in place.
Solutions will come from a strong national as well as international response. In 2004, 29 of the 41 high-burden countries had national policies on HIV and TB. This needs to be scaled up. India already has 100% coverage for TB treatment under DOTS and is now in the process of implementing a national plan for TB/HIV co-infection. The challenges are many. If the world has to meet the target of cutting deaths due to TB and HIV/AIDS by half by the year 2015, it can no longer ignore this deadly partnership between the two diseases.